So good morning, ladies and gentlemen. Of all of the surgeries that we do on an elective basis on human beings, we in orthopedics can contribute probably most to the improvement of the well-being of mankind with hip replacements if done for the right reasons and under the right techniques. Sadly, some patients do suffer complications over time, and one of them we're going to discuss here today, and that is fractures around these hip replacements specifically. It is my pleasure to introduce three eminent speakers on this. Dr. Brian Daines, a fourth-year resident who's going to do a fellowship in joint replacement, has a strong academic interest, and he's going to be partnered with Dr. David Barei, associate professor in orthopedic surgery. He is also one of the mainstay trauma surgeons of national reputation at Harborview Medical Center. And he's going to be partnered with Dr. Howard Chansky, our vice chair in orthopedic surgery at the University of Washington Medical Center and at the VA, and a joint replacement surgeon. With this, I'm going to ask Dr. Daines to take the lead and host us with a number of cases. Thanks, Brian.
Well, I'd like to thank Dr. Chapman for that kind introduction. My name is Brian Daines. I'm one of the orthopedic residents here at the University of Washington. I'm grateful that Dr. Barei and Dr. Chansky could be here with me today to discuss this interesting and complex problem. We're going to be discussing periprosthetic fractures. We don't have anything to disclose. No outside funding or grants have been given to us. I'd also like to thank Dr. Robert Winquist, Dr. Paul DeWillius, and Dr. Sean Nork for their aid and help in developing this slide presentation. So periprosthetic fractures is a complex problem that's increasing in prevalence. There's over 200,000 hip replacements done every year. 1% of the primary hip replacements result in a periprosthetic fracture, and then about 4% of the revision hip replacements result in a periprosthetic fracture. Now these are, with our improvement in technology and the fact that patients are living longer, this is only a problem that's going to grow bigger. There's about 25 in 1,000 total hip replacements over a 15-year period that result in these periprosthetic fractures. So really, we're only seeing the tip of the iceberg concerning this problem. It's important because it has a high mortality rate in the first year, a mortality rate that approaches that of a hip fracture, around 15%. As you can see in the survivorship curve, over the first 3 and 4 years following when you have a periprosthetic fracture, it mimics or mirrors that of the hip fracture mortality rate. So who gets periprosthetic fractures? It's usually older patients with multiple comorbidities such as coronary artery disease and diabetes. These patients have poor local bone quality or osteoporosis. They may also have associated joint ailments, total knee replacements. And as I mentioned before, revision surgery tends to have a higher percentage of periprosthetic fractures, so you're already dealing with a patient with poor or potentially poor bone stock. The mechanism of injury is usually a low mechanism, such as a ground level fall. In our younger patients who are getting total hip replacements, sometimes they can be involved in a high energy injury. And then there's a group of patients that really have no trauma, but that do have an insidious onset of pain. In these patients, we need to worry about osteolytic lesions and potentially occult infections. What we want to do today is present a general approach in dealing with periprosthetic fractures, focused in on the stability of the prosthesis, really evaluating the fracture characteristics, and getting a good sense of who the patient is. As you can see in these pictures, we have stable and unstable fracture patterns. This is a stable fracture pattern. You can see that the stem is not migrated or subsided. And this is an unstable fracture. You can see it's a long spiral fracture that goes through the stem, and the hip prosthesis appears to have migrated. Determining whether or not an implant is stable or is unstable has important ramifications in what operative treatment is used. Eng in 1990 gave us a list of different things to look at radiographically that can help us with the stability, assessing the stability of stems. We can look for the presence of spot welds on the compression side of the femur, lack of radiolucent lines, and then look at for pedestal formation, calcar remodeling, or no migration of the stem. When we're evaluating cemented components, again, we look to see if there's migration, whether or not, and that would be associated with a definitely loose stem. We also look around the stem for radiolucent lines around the bone cement interface, and that would be a probably loose stem. And then if there's 50 to 100% of a radiolucent zone around the implant, then that could be considered a possibly loose stem. So You can see a shortened fracture around the femoral stem with angulation. And then on this side, you can see that there's poor bone quality and comminution of the fracture. So when looking at the fracture characteristics, it's important to assess those because, again, they determine management. Now, our goals are to obtain an accurate diagnosis, because with that accurate diagnosis, we can then choose either to do an open reduction internal fixation versus a revision arthroplasty. The goal is to obtain good long-term function, fracture union, and then maintain or obtain stability. In these patients, it's paramount important to get them mobilizing early. In review of the biology of fracture healing, we all know that it's important to preserve the blood supply to the fractures. We do this by limiting the surgical dissection, and then we need to obtain an accurate fracture reduction with robust fixation. Today we're going to focus in on fractures around total hip replacements. When thinking about a total hip replacement, we need to remember the bone stock, really get a good sense of the history of what has been done on these patients priorly by obtaining operative reports if we can, and then by looking for the presence or absence of cement. We also need to assess where the fracture is located around the femoral component, and then really get a good sense of whether or not the implant is stable. Now, in the 1990s, Duncan and Massari developed a classification system that focuses in on these three important points and gives us some clues on to how to treat these fractures. If you look here, you can see that type A involves the greater or the lesser trochanter. Type B is associated with fractures right around the stem of the implant, and then type C are located distal to the implant. If you look at the type B, you can see that we're looking at the bone quality as well. This is a high inter- and inter-observer reliability, and it's been validated in studies in Europe and North America as a classification system that can be used to effectively manage these patients. What we're going to be talking about today is the most common type of fracture, that's around the type B fractures. So the type B1 fractures are a stable implant, and that can be treated with operative open reduction internal fixation. And then the type B2 and B3 fractures, they're an unstable implant with the difference in a B2 you have adequate bone stock, and then in a B3 you have inadequate bone stock. So again, back to that theme of assessing whether or not an implant is stable or unstable. If there's a continuous lucency around the cement stem, then you would assume that there's some loosening. It's important not to always assume that if there's a fracture through the cement mantle that the implant is stable. And so if there is a fracture, you need to be wary and check intraoperatively the stability of the implant. Now, the reason this is so important was shown by Lindell in a study in 2006. B1 fractures often have a simple spiral low mechanism of injury type presentation. And B2, you would assume, would be a little bit more complex. Lindell found that the B1 fractures had a poorer result when compared to the B2 fractures, and he thought that this was because the unstable fractures were being initially thought to be stable fractures and treated operatively. Also, Bethayan had found out that in 75% of his patients, there was some underlying stem lucency. There's multiple treatment options for these fractures. You can see on the left here, there's a variety of plate and cable constructs, plate and screw constructs, and then even allograft bone struts. Now, it's the cement mantle and the prosthesis that causes the difficulties with proximal fixation. It's hard to get bicortical screw fixation, and then unicortical screws, cables, and locking screws have questionable fixation as well. Historically, compression plates have been used. These have certain advantages, specifically in that you can visualize the fracture, obtain a good direct reduction, and then establish rigid internal fixation. The disadvantages have to do with the amount of soft tissue dissection, and then again, the difficulty obtaining bicortical screw fixation. Plate and cable devices have been used to deal with that proximal fixation issue. As you can see here, it's the classic Ogden concept with some screws distally and cables proximally. Menin clamps and plate and band devices have also been developed. Now, cable and plate devices have the advantage of not interfering with the cement mantle. However, they give poor control to axial force, and in patients who have varus malreduction or a varus implant, they've been shown to lead to a high rate of failure. Corton in 2009 had a good study where he assessed these plate and cable devices and found in certain fracture types they actually had good union rates and return to function. An interesting thing about his study, too, is what he did is he took 45 different fractures, which he initially thought were stable, and then did a surgical dissection and really assessed intraoperative stability. And he found that 20% of the fractures that he initially thought were going to be stable did indeed have some instability as well. Now, the fractures that were amenable to this treatment were the simple spiral fractures that I mentioned earlier, and if they had any comminution on the medial cortex, then this was not a good construct for these fractures. As you can see here, 29 out of 30 had good union rates, and they did have minimal complications. Cortical allografts have also been used for periprosthetic fractures. These are biological bone plates that augment the stability and strength, as well as increase the bone stock. They offer less stress shielding, which is an advantage. Their disadvantage, of course, are the cost, the availability, and the theoretical risk of disease transfer. At about 4 or 5 months, they tend to reabsorb, so there's a period where the construct weakens as well. Haddad studied these with 2 different constructs, lateral plates and a cortical strut, and then 2 cortical struts. And he had good success with this. You can see here a series of x-rays with an injury film, the allograft construct, and then eventual healing at 28 months. Locking plates have been designed. The benefits are that they're a bridging construct. They preserve blood supply. In osteoporotic patients, they offer the advantage of being a fixed angle fixation. Difficulties with these were shown by Butaro in 2007 when he had a high percentage of his fractures pull out. Ricci had a good study in which he employed locking screws and cortical screws distally with locking screws proximally. He did an indirection reduction with a single lateral plate. Again, you can see that he had a good union rate and return to function. This slide illustrates the minimal surgical approach. Technical tips that he learned were that you need to overlap the prosthesis, avoid stress risers proximally and distally. Locking plates are good for osteoporotic bone. You can use cables as adjuvant therapy. And probably most importantly, they minimize the soft tissue dissection, preserving the blood supply to the fracture components. Out of Harborview, we had a recent study that presented 10 cases using the long lateral spanning locking plates. You can see here a series of injury films and then the eventual construct. They had 10 out of 10 unions and did not use cortical allograft or cerclage wires and found that the spanning locking plate was sufficient fixation. They had no major complications. Again, you can see another example of an injury film, long spiral fracture, and then the long spanning plate. An interesting study was done by Daines in 2000 in which he did a biomechanical study evaluating the fixation strengths of the different constructs that I've talked about, the cables and screws, unicortical and bicortical screws, cables and screws, and then allograft struts. What he found in summary is if you're looking at the Claston-Ogden construct again with distal screw placement and cables, that if you add a unicortical screw to that cable construct, you get improved proximal fixation. If you replace the cables with unicortical screws, again, you get increased proximal fixation. And that both of these constructs had more early strength than just the 2 allograft struts and cables. There have been a variety of studies demonstrating success in dealing with these fractures. Here's just a summary slide of some of their results. We want to move now on to stem instability. This is a difficult problem because now you have a loose stem and potentially with the B2 classification, and then you have a loose stem with bone loss in the B3s. Revision arthroplasty has certain advantages. They have been shown to have a lower mortality rate, and perhaps that is due to the fact that you can begin earlier weight bearing with these revisions. The disadvantages have to do with the complexity of the fracture, the increased operative time, and the potential for greater blood loss. Now, the principles of revision are to preserve the proximal bone, transverse the fracture site by at least 2 cortical diameters, and then potentially use an allograft strut to increase bone stock and control the rotational forces. Similar to operative fixation, there's a variety of treatment options ranging from cemented stems to fully porous stems, and then to the more salvage type procedures such as an allograft prosthesis composite. Cemented stems have been used historically. Their advantage is they give good proximal early fixation. The disadvantage really has to do with the fear of the cement getting in between the fractures and causing a non-union. Also, in revision arthroplasty, cemented stems have been shown to have less favorable results when compared to long, porous, fully coated stems. These are now reserved for the elderly with poor bone, and it's important to have a good anatomic reduction with these fracture patterns. Cement constructs have been tried. They had good union rates. They preserved the cement mantle. Again, you need an anatomically reducible fracture with a well-preserved cement mantle. Now, long cementless stems or porous coated stems are the gold standard now for revisions. What their advantages are, you get a good distal and intermedullary fixation and a good biological bone fixation, or you have the potential for biological fixation. The disadvantages really have to do with proximal stress shielding, the potential for subsidence. You do have to have restricted weight bearing for a period of time, and then again, the bone stock has to be sufficient for distal fixation. McDonald demonstrated that this is a technique that is reliable. He had good success with union of fractures at about 4 months. Now, this slide highlights some of the difficulties with revisions, and that has to do with perimorbid events such as myocardial infections. Springer in 2003 compared 4 of the different revision techniques that I'm talking about, namely cemented stems, proximally porous coated stems, extensively porous coated stems, and then allograft or tumor prostheses. After a 5-year follow-up, he found that these techniques restored function in most patients. However, there were problems with prosthetic loosening and fracture non-union. The important thing to remember from this slide is the best results were from uncemented, extensively porous coated stems. Now we're going to move on to some of the more salvage techniques. These have to do with distal fixed components. Advantages have to do with the fact that they're uncemented. They preserve bone stock, and they give good axial and rotational stability distal to the fracture site. Disadvantages, as I mentioned before, have to do with subsidence and that they're not applicable for all fracture types. The Wagner revision stem is a distal fixation that has had some success in the last few years with union and returning to function. Their complications are associated with the fact that it's a single component with a single offset without any modularity. Now, fluted tapered stems are another distal fixated revision technique. You use a direct lateral transfemoral approach. There, again, were some complications with dislocations and non-unions, but it has proved to be a technique that can be used. Now, proximal femoral allografts, these are a salvage technique. They preserve the bone stock and potentially preserve reattachment of the soft tissues. Disadvantage is a prolonged period of non-weight bearing. As you can see, here is a B3 type fracture with poor proximal bone quality. It's a displaced fracture with loosening of the stem, and it's been replaced with the proximal femoral allograft. Now, proximal femoral replacements are another salvage technique. These are for the older, low-demand patients. The complications are related to poor bone stock and lack of soft tissue attachments. Again, here's an example of a proximal femoral replacement. You see a type 3 type fracture with poor proximal bones, some comminution and subsidence of the stem, and leading to the proximal femoral replacement. Now, I'm only going to mention briefly the treatment of the type C fractures. Basic principles are to span beyond the prosthesis to avoid stress risers. You get good proximal fixation. So now we're going to move on to our cases. I'd ask Dr. Chansky and Barei to come. All right, so our case number 1 is an 86-year-old with hypertension, atrial fibrillation, a history of bilateral hip replacements, who had a ground-level fall. Baseline walks with a walker, presented supratherapeutic on Coumadin, and then has a history of a perineal palsy in the ipsilateral leg. So, Dr. Barei, how do you initially approach the management of this patient's fracture?
You know, I think while assessing stability is critical to determining a satisfactory treatment algorithm or treatment plan, And a lot of it is based on radiographic assessment. I think one of the first things, the simplest things, and one of the most reliable things for me is to simply talk to the patient and find out how their prosthesis has been functioning, what it was done for, and how it's been working up until the incident event. And very often the patients will give you a real good clue if their prosthesis has been becoming loose prior to that. So I fold the history in with their radiographic assessment of stability and come up with a treatment algorithm based on that. Of course, I'm looking at the fracture pattern. I'm looking at all the other radiographic parameters that you nicely outlined.
And Dr. Chansky, when you're looking at these films, what are things you're looking at?
So it's pretty much what Dave said. I think the most important thing is the history, because you can even have a radiographically loose implant, but the patient might be asymptomatic. It could be a fibrously stable implant. And then in this particular case, some of the things that as a joint surgeon I would notice is that there might be a small proximal fracture through the lateral cortex. So maybe this fracture is more of a Vancouver B. And it also looks like there's pretty extensive radiographic lucency around the stem, and that might be from osteolysis. It looks like this patient probably already has undergone at least one revision based upon the length of the stem and the cage used to reconstruct the acetabulum. So if I were reconstructing this, I would be concerned, is that prosthesis loose, and would you need to be prepared to actually revise it in addition to fixing the fracture?
So Dr. Barei, what would be your operative approach?
Well, for me, assuming that the history fits with a stable prosthesis and the radiographic examination reasonably well corroborates that history, and factoring in the patient factors, age, functional level, and other comorbidities, my operative approach for fixation is in simple fracture patterns to go for direct reductions, anatomic reduction, absolute stability patterns, and neutralization type implant. While I do appreciate that percutaneous surgery has the appearance of minimally invasive and biologically friendly, I think that these simple patterns really respond well to direct visualization with good soft tissue technique to get an anatomic reduction.
And then how do you decide on proximal fixation?
Proximal fixation, I think, is what you outlined. I think that these patients have typically poor bone quality, and I think a lot of it is all about proximal fixation. My choice is to obtain locking screw fixation to the proximal segment as much as I can, and I try to avoid cables unless absolutely necessary, and I really work hard to try to get screw fixations in the proximal segment.
Okay, and so this patient underwent an operative fixation. Can you discuss a little bit about how you obtain the fracture reduction?
For me, the fracture reduction is obtained with open direct visualization of the fracture, once again using a lateral extensile exposure. I often find that percutaneous placement of plates in an area of previous scarring, like would have been done with this patient's previous surgery, is quite difficult, and placement of the plate laterally in the proximal segment is critical to being able to obtain screw fixations in and around the stem. Or the cement mantle if it was present in other situations. So for me, it's a long lateral extensile exposure. My usual approach is to try to be as biologically friendly as possible. And one of the simplest ways to do that is to place the patient in a lateral position to do a lateral exposure of the thigh. And what this facilitates is the avoidance of putting circumferential retractors around to the medial aspect, and it really allows the soft tissue envelope to fall away from the lateral aspect of the femur. My philosophy is plate the entire length of the femur. They typically have osteoporotic bone. I like to get as much proximal fixation as possible and supplement that with a nice long lateral plate, and really try to make the fracture participate in the stability, i.e. get a direct reduction in interfragmentary compression if at all possible.
And so you were able to do this in this fracture. You can see that the long lateral plate with the excellent reduction, and then the follow-up at 7 months demonstrating union. So we're going to move.
Yeah, let me ask a question here. So how rapidly after the fracture happens do you do the surgery? Is that something you do in the middle of the night? Do you wait for a couple of days?
I look at these exactly. It's the same patient population in mortality and morbidity rates that you see with hip fractures. So I think one of the important things is planning. These patients need to be seen by the medicine service or as a team approach to make sure their other comorbidities are assessed, are evaluated. The patient needs to be assessed for stability factors regarding the prosthesis, and then you really have to have the appropriate implants and the people that are able to help you with those appropriate implants, specifically the scrub nurses, the circulating nurses, and you have to have all the available implants that you need. This is typically not a middle of the night operation. It needs to be planned, and there may even be special requirements for some of these implants to achieve fracture fixation, and certainly for a revision situation.
Yeah, most of the literature on hip fractures indicate that there's probably a sweet spot in terms of postoperative morbidity and mortality, and that's somewhere between 24 and 72 hours. And we often fix these as a team, and besides getting the equipment, it takes a little bit of planning to get the trauma surgeons and reconstructive joint surgeons together. So somewhere in that window, I think, is ideal.
Certainly with some of these ones where I have equivocal ideas about radiographic stability, Howard's the guy I call and I ask Howard, Howard, have a look at this stem and tell me if you think this is one to fix or one that you should be managing with a revision. I think we work quite well with that whole thing together.
Dr. Henley?
Brad Henley, Harborview. Two questions. As a matter of routine in the evaluation of these patients, do you obtain preoperative laboratory studies, and if so, which ones do you routinely obtain and how are they stratified? Secondarily, do you obtain any advanced imaging studies in any of these individuals, including scanning, MRIs, etc., and what are the indications for those?
I'll let Dave talk about the routine trauma labs, but in terms of joint-specific labs, there's really not anything to get unless you're concerned about a preoperative infection. So if it's a patient that came in complaining of some groin pain or thigh pain and there's nothing obviously wrong with the x-ray to indicate that it's grossly loose, it's probably worth checking those labs to see if there's the possibility of an infection. Of course, they also might be elevated just in the setting of trauma. So if you're really concerned, you would need to check either intraoperative cultures or perhaps even better a frozen section or a couple of frozen sections.
Typically, because of the ages of the patient and the fact that they've been involved in a fracture which may have had some sort of higher energy mechanism, obviously your basic screening blood work would be in order. These patients are going to have some form of blood loss secondary to their injury. They'll have some form of blood loss secondary to their surgical procedure, so they'll need to have a basic blood count. Blood may need to be crossed and held in the event that they may need further transfusions at the part of their hospitalization. Some of the other things that you may want to consider, I think this is a person-specific situation, are nutrition labs, as well as other markers for bone healing, such as vitamin D and calcium levels, which really I would have our colleagues in medicine help us with some of those determinants to help them with their postoperative course. Many of these things can't be corrected preoperatively, of course, but they sure can be part of the postoperative care of the patient.
And in terms of radiographic studies, it's basic x-rays. Things like bone scans, in the setting of trauma really aren't going to help you to decide if the prosthesis is loose. There's some experimental work using MRs to actually look at loosening of implants and looking at the fibrous membrane around the implant. And then the only other study that I would occasionally get is a CT scan if there's an acetabular fracture along with the femoral fracture.
Dr. Kringle?
Couple questions. A lot of the older patients that come in now are on Plavix, and I have a question about what you do for the patient on Plavix, how long you wait, whether you use platelet transfusions or not. And is there a role for the trauma surgeon to fix the fracture despite a loose stem and then do a revision later? And lastly, does the presence of loosening, is it a risk factor for periprosthetic fracture?
I think I can address a couple. Howard, maybe you want to address the Plavix question. Certainly, I think some of the studies that have been shown where the patient with insidious pain and no real trauma really look for an osteolytic lesion around the tip of that stem or somewhere along the location of that stem. So I think that, loosening will have some potential risk because of the thinning of the cortex and essentially a stress zone. And that fits in with the philosophy of fixing these, of plating the entirety of the femur. And one of the most challenging situations is dealing with these patients when they have a non-union. And invariably, although Brian showed a nice case with a plate broken, it's rare that the plate breaks. It's much more common that you've had a loss of fixation either in the proximal or distal segment. And I think that just demonstrates how difficult it is to get fixation in poor bone quality in and around a stem of a prosthesis. I think that I would also ask Howard, certainly my philosophy as well is in many of these people, particularly the older person with lower demand or the person that's been significantly injured as part of their femur fracture, that they obtained it either in a higher energy mechanism like a car accident rather than a ground level fall. They have other things going on. They may have a splenic injury, they may have a head injury or some other of these things. And I think that fracture fixation in that acute period of time is good physiologically for them. And I also would think that it would make a subsequent revision procedure a little bit more predictable should they need that down the road.
Yeah, so I would agree with what Dave said. I mean, ideally, you want to do all the surgery in one setting if you can. But if it's someone that's been involved in high energy trauma, I mean, it may be physiologically even better to just get the fracture fixed. And at least when you do that revision in a safer setting, it will be orthopedically an easier operation. In terms of the Plavix, it depends on what they're taking it for. And if it's someone who's had a recent stroke or recent MI and perhaps has had stents put in, then you can stop the Plavix, but obviously you have to bridge them with something. And in terms of just managing the Plavix, unless it's life-saving surgery, in this setting, I would actually wait 5 to 7 days.
I think that patients would be interested in learning what their expected function would be in the post-operative period. For example, when they could start moving their hips and knees and how soon they could return to function with weight bearing. That might be of interest.
So if there's one advantage to doing revision joint surgery in the setting of a periprosthetic fracture, it's that you can almost always weight bear that person as tolerated, right after the surgery. It's the unusual periprosthetic fracture that I revise that I actually have to keep them partial weight bearing for several months. Whereas if you fix them with extramedullary fixation, you can be a little more aggressive with a locking plate, but then you are often waiting 6 to 12 weeks for them to fully weight bear.
Yeah, I think I agree 100% with what Howard said. I do try to find ways that I can maximize my fixation and fracture stability, if at all possible, to facilitate some kind of early weight bearing, whether it's simply to stand, to transfer for the first 6 weeks, or to frankly let them begin doing some weight bearing. I think that's really, really important. But I am cautious with doing that in the fracture situation for sure.
All right, so we're going to move on to our case number 2. This is a 79-year-old female with a 20-year-old total hip replacement, as was previously alluded to. This is a case with the preoperative groin and thigh pain, and we're going to ask Dr. Chansky how he would approach a patient with preoperative hip pain and what treatment modalities is he thinking of.
The most important, aspect of the decision-making process is how they describe their symptoms. And so if it's somebody that has startup pain, pain when they get out of bed in the morning or pain after they've been sitting down for a while and they take their first few steps, then I would really be concerned about either acetabular or femoral loosening. If it was more constant pain, particularly pain at night, pain when they were sleeping, that would lead me in the direction to try to figure out if they perhaps had a pre-fracture infection.
Dr. Barei, what do you think about this radiograph?
Well, this one I'd be quite concerned that the stem is loose. I see some certainly lucencies along the entire medial cortex of this. But one of the other things I may be concerned about is the relative asymmetry of the acetabular liner, which may suggest that the acetabular component is also becoming aged and worn as well. This would definitely be one I'd be calling Howard on to have a look at this prosthesis.
So Dr. Chansky, how then would you approach this patient operatively, and how would you reduce this fracture?
So I think Dave brought out the point about the acetabulum, and it's easy when you see a fracture to just sort of, focus right in on that and forget that there's another component in there. And the fact that she was having groin pain in addition to thigh pain makes me think that she's probably having quite a bit of inflammation, synovitis from polywear, in addition to the fact that her thigh pain was probably from what looks to be a loose stem. So this is one that, in addition to fixing the fracture, you really have to entertain revising the hip either right away if the patient is stable enough to do all of that surgery. And so my technique for this would be to wait to dislocate the hip until I actually stabilize the fracture. It's much easier to dislocate it after you have the fracture, put together, and you can use the leg as a lever arm to dislocate the hip. And so that's how I would revise the acetabular component. So that would be essentially the last stage of the procedure. And in terms of fixing the fracture, it's important to get some provisional fixation before you put the stem down. And you can do that manually by using several clamps on either side of the fracture. But particularly in a transverse fracture, it can be very hard to control the femur while you're trying to manipulate the leg and ream and broach and then get an implant down. So what I have been using that I basically stole the idea from my Harborview colleagues is to use these short provisional fixation plates. And I've not seen them used in any other studies or radiographs that I've seen at meetings, and they really make putting these fractures together much easier. You can see here that there's 2 Verbruge clamps there, and it still leaves room to put a small plate across the fracture. And after I do that, I can pretty much take those clamps off usually, and I can ream and broach and put the new implant down. The other thing the postoperative film reminded me of is that she's really a Vancouver B3 in that she has significant femoral bone loss. And so the other thing that I did in this case was to use a femoral allograft strut over that lateral cortex. And I agree with Dave, if you can avoid using cerclage-wise, I don't think they're quite as evil as the trauma surgeons do. But if you can avoid using cerclage cables, that's ideal. But if you're putting a strut graft on, you need to cerclage it. And I'll just say one thing about the strut graft. So they often don't fit the cadaveric struts, and so I will contour them with a high-speed burr. I'll really try to round off all of the edges, and I'll use some demineralized bone matrix in the interface between the graft and the native femur. And I am sometimes amazed by how well incorporated these things look after 6 months.
Dr.
Let me
Chapman?
just ask a question again. So I think Dr. Henley and Dr. Kringle both raised the question of an occult infection being in there. If you opened up this patient, I assume you'll see some form of relatively undifferentiated, more or less mucousy fluid around there. If you send that off for a gram stain, which I assume you'll do, and there's a question of an infection, how does that change your intraoperative procedure? Would you still go ahead with a stable internal fixation, or would you just do something different?
So it's a great question. If I were really concerned there was a fracture, I'd send both for gram stain and frozen section to look at the number of neutrophils. And it's important to stabilize the fracture. The patient can't be mobilized out of bed. They are at risk for getting urinary tract infections, pulmonary infections, decubitus ulcers. So it's important to stabilize that fracture regardless. And depending on the anatomy, I would have no hesitation to put a plate in if I needed it in the setting of an infection after I debrided them and washed them out. And then I would keep them on suppressive antibiotics, and then at some point go back in and do the secondary stage, which would be to put in the prosthesis. Ideally, you would be able to use a temporary antibiotic-impregnated cement spacer. So if I could fix it that way, perhaps with that and 1 or 2 cables, I think that would be best of all. Then they get high levels of antibiotics leaching out over a month or so. And presumably that would give them also enough stability to at least be able to be mobilized.
All right.
Does Dave have any thoughts on that?
No, I think that's a great question. From my point of view, fracture stability and suppressive antibiotics would definitely be the way to go. You need to stabilize that fracture for the patient. You have to do that. And once again, if there was an occult infection, my approach would be to stabilize the fracture. If it was not a grossly loose prosthesis, obtain fracture union, and then have a staged, what I would think more predictable, staged reconstructive revision type prosthesis by one of my colleagues.
So we're going to move on to case number 3. This is a younger patient, more active, 59-year-old, history of a left hemiarthroplasty for a femoral head or neck fracture 10 years prior, had a fall off a couch. History of COPD, occasional alcohol use, previously functioning well with virtually no pain. So on this, Dr. Barei, how does your management change for the younger, more active patient?
Boy, this you can make strong arguments for a view or a vantage point for managing this. My personal opinion is that I'm happier typically with the bone quality, and so this fracture historically is doing extremely well until she had a very discrete event which caused this fracture. There's no prior pain, but she does have an implant that is likely not going to be a long time durable implant. She's got a hemiarthroplasty at age 59, which was put in when she was 49. My approach is really the same. She's got a simple fracture pattern around the tip of the stem of what I believe to be a well-fixed, stable prosthesis. This is going to get a direct reduction, interfragmentary compression, absolute stability type construct, and let her get back to her activities as much as possible, with a word of caution, understanding that this may hasten the loosening or the wear of the prosthesis to where she would need a revision perhaps sooner than previously felt.
And what do you think about these films, Dr. Chansky?
So it's interesting because she has what looks like a bipolar endoprosthesis in there, and if you look at the natural history of those, typically you can expect a good 5 to 7 years of functioning out of them before patients begin to get groin pain from wear of the acetabular cartilage. And if you look at her x-ray, it looks like that's already happened, and perhaps that cup has even migrated a little bit into the bony acetabulum. So if I were doing this, I would have a long talk with the patient and tell them that I can add about 30 minutes to the case, a little bit more complexity and blood loss, and I would strongly encourage them to consider letting me revise the acetabulum, turn this into a total hip, one procedure. The downside of that is that in some studies, dislocation after revision hips have reported to occur in up to 25% of patients. I mean, I think that's not quite right, but certainly, 5% would be a reasonable number. And so I would fix the fracture first, and then I would ideally dislocate the hip and put a acetabular component in.
So how did you approach this patient, Dr. Barei?
Same way as before, a lateral extensile exposure. My plan was to be using locking plate fixation, and typically in the proximal portion, which is where really all the challenges are, I think you can get good fixation usually behind the prosthesis. Often the prosthesis is placed obviously to replace the femoral head and neck, which is a more anterior structure, and posterior to this we usually have a corridor of bone or available osseous structures where we can typically direct screw fixations into the region of the lesser trochanter, which gives us a really good proximal stability point to help stabilize this fracture.
Okay, and these are the postoperative x-rays indicating union of the fracture. Moving on, number 4, this is a 66-year-old with a history of a right total hip replacement, 5 years prior, involved in a motor vehicle accident. Now this is the polytrauma that we often see at Harborview. They had rib fractures, a sacral fracture, iliac wing fracture, and then a comminuted right periprosthetic fracture. Of note, this patient was previously functioning well with no pain. So Dr. Barei, what do you think about these images?
Well, these images corroborate that high energy mechanism. If you look particularly on the lateral view, you see that there's extensive comminution in the anterior cortex of the femur. There's comminution of the cement mantle, which I don't think I've ever said that before. But this prosthesis is loose to me in an otherwise fairly sick individual, and this is definitely one that I would really be favoring a revision type prosthesis for this. I don't think this is a fixable fracture for me in my hands, and I think that this would be best served with a revision when the time is right, given his other injuries.
So Dr. Chansky, what are the revision options for a patient like this?
So this patient actually was seen at Harborview, and after he was stabilized, we operated on him at the university. So in terms of options, I'm not sure you can quite appreciate that lateral film with the lighting in here, but his femur was basically exploded. And so in an older person, the choices are somewhat simpler. You can put in a proximal femoral replacing prosthesis, basically a tumor or oncologic prosthesis, a big piece of metal, and then pot that in distally. The other thing you could do in someone who was less active would be to use a massive allograft prosthesis composite. And again, given how his comminution extends somewhat distally into his isthmus, I think you would be stuck having to basically pot that in with methyl methacrylate. And so there aren't really any simple options that I think would fit somebody who's 59 and extremely active. Part of the history that Brian didn't get into is that this is someone who bicycled basically hundreds of miles a week. And so I went in there with all intentions of trying to basically salvage his native femur somehow, just because of his age and his activity level. And when I went in there, as usual, the appearance is even more striking than the preoperative X-ray. And there were basically lots of small fragments left behind. And so in what became a fairly long case, I somewhat tediously tried to put these pieces back together. And so again, I used that provisional fixation idea that came from the trauma literature fixing tibia fractures. And you can see that I used 2 of those plates distally down around the isthmus. You're trying to put a puzzle back together, and it's actually difficult without anything down the center of the tube to help stabilize it. And so I'll usually use things like my canal plug inserter to drop down into the femur to help stabilize that internally. And then I use these provisional fixation plates. I had to use a trochanteric cable plate proximally to anchor down his trochanter. And one thing that I needed some cerclage cables in this, and the dissection to get to all of this, you're already stripping a lot of the blood supply away. So I'm not sure it's that much of an additional injury to the blood supply to use the cerclage cables. But in addition, it's one of those rare cases where I used a strut. I wasn't quite sure that I needed to use it, but I actually used it to help with fixation also in this case. And so this is one of the only fractures I can remember fixing with a revision where I did not let him fully weight bear, obviously, for about 3 months. I mean, this bone is dysvascular. It takes a long time for it to heal. So again, for me, I thought this was obviously higher risk in terms of infection, in terms of blood loss, longer surgery. But I thought to just save his native femur was the best thing I could do for him, even if he subsequently needed another revision.
So he went on to do well and sent a nice note back that he'd been going on a 330-mile biking trip. Yeah,
this was a year post-op, and you can see he was riding a woman's bike, so he could easily get on and off the bike. And he had a cane that he still used, I think he told me, when he was climbing hills, and he subsequently did fine.
So we're now going to move on to another case with a 72-year-old fall from standing, history of an ipsilateral total hip and total knee replacement. So Dr. Barei, when you see a fracture like this, what are you thinking about?
Enough said. Well, whether you want to classify this as a B1 or a supracondylar distal femur fracture, I think that fixation challenges are, of course, all I think about. And I think this is maybe not even amenable to any kind of revision prosthesis other than removing the femur and doing some fairly heroic activities. This takes a good deal of planning. You need to make sure that you have a variety of implants available to be able to dodge the large stem that's in her femur, as well as getting enough secure fixation in the distal segment. So this is really challenges on either side of this fracture. Fortunately, it's minimally comminuted, and this is definitely a fracture that I think is best treated with ORIF, if at all possible, unless there's a revision prosthesis that could be used for that. But I would think it would be quite challenging, Howard.
No, I agree with everything Dave said. These distal fractures are tricky, and he and I have collaborated on a lot of these patients. And one option, if that long stem weren't there, would be to revise the knee with a long femoral stem on that side. But I think given the degree of bone loss and that long, seemingly well-fixed stem, I would try to fix this with a locking plate.
So how did you achieve fracture reduction in this case?
This is lateral extensile exposure, as said before. This is amenable to a clamp application, and once you reduce the fracture, you realize how straight the stem is, and likely had a role in the location of the fracture, being right at that tip of the stem. Fortunately, by going proximal, quite proximal in this, we're able to actually get screws anterior to this prosthesis and thereby give it kind of a buttress to keep the stresses from wanting to traverse or come out the anterior cortex again. Locking plate fixation screws as distal as you can get them and as proximal as you can get them, a long, stout plate to help control bending forces, axial rotational forces, and a small amount of bone graft posteriorly to help encourage this to unite.
And so that brings up the question about allograft struts. You've mentioned them a little bit. Dr. Chansky, what do you think about their role?
So allograft struts can be particularly useful for restoring bone stock around the hip. Around the knee, it's a little more difficult just purely for anatomical reasons because you have the flare of the condyles. The exposure to the posterior aspect of the distal femur is a little tricky with the femoral artery being there. And so, and also in this case, ideally you would have wanted your strut directly anterior, and then you're getting into the suprapatellar pouch. You also have a smaller soft tissue envelope, so if you expand that volume with more space-filling objects such as a strut, it can get harder for the patient to regain any motion. So in this case, a strut would be useful anteriorly, but I would probably do what Dave did and maybe add a little bit of bone graft, particulate bone graft to the anterior cortex. But there's not much you can do about that stem being there.
Brian, I have a question to you. In your review of the literature, did you see that patients with cemented stems or uncemented stems were more prone towards developing these periprosthetic fractures?
Oh, I didn't get a good sense of if there's a difference in the prevalence rate. What I found was that definitely in revisions where there's a poor bone stock, those have a higher percentage of periprosthetic fractures. And I think historically more cemented stems were used, and so they're more prevalent, so there might be more periprosthetic fractures with those. But with the newer fully porous stems, there is the chance of really trying to get a tight press fit and causing intraoperative periprosthetic fractures. So that's what I found.
Then the sequitur question to our two experts here is, which type of prosthesis is easier to fix afterwards, a cemented or an uncemented stem? I mean, it looks like that one case that you showed, which did so beautifully, the bicyclist, that was just a nightmare to fix, and that was in part due to the cement mat that was around.
Well, right. That's a great point. One of the reasons that I actually used the graft there is because after I had chipped away all of the well-fixed cement from the fragments of his femur, I obviously had a little less bone stock to work with. So in terms of revising a hip, all things being said and done, it's nice when there's no cement to deal with.
For me, for fracture fixation, I actually would prefer a cement mantle because it's drillable, and I can insert screws, rather than that space being occupied entirely by a metallic stem.
Dr. Wagner, did you have a question?
I had a general question about the last couple cases where there's a lot of comminution and there's real concern for malunion or malrotation. How do you assess rotation in a lateral position or in a supine position?
So another good question, because you're often struggling with that in these cases. And the things that I use are the linear aspera and the patella, and then the femoral neck. And if you kind of triangulate down the leg between those three bony landmarks, you can usually come close. And obviously, the foot, but it can be a little tricky when they're severely comminuted like that.
Sometimes, when I'm doing these open, I can find a cortical interdigitation or reassemble some clue to give me a rotational control. One of the things that's sometimes really quite useful is if there's a small amount of the prosthesis that's visible at the fracture site, by looking at the corresponding zone of the proximal end of the distal segment, you'll often get an idea of where that had been resting up against, or a portion of cement that just looks like it fits properly. So I use all available clues, and if there is a zone that I can get an interdigitation or a read, if you will, for that, that's all I need, and then I know that rotation is going to be pretty darn close.
The other thing I'll do intraoperatively, if I'm getting ready to take one of these apart, I'll start making marks with either the cautery or an osteotome on my different fragments, so when I go to put them back together, I can actually line them up again.
Well, we're out of time, so I would like to thank Dr. Barei and Dr. Chansky.
Thank you,
Thank
Brian.
And I want to thank Brian for putting together this very excellent presentation. I think in conclusion, we can say these are very challenging injuries, and I was very impressed with how across different disciplines of trauma and adult reconstruction surgery, and across different hospital lines, people put their heads together and communicate to try to get the best result for patients with very difficult problems. So thank you for educating us.
Thank you.
Thank you.